Mr. Mowia Dabora. He's a plastic and breast surgeon. He's an assistant professor in the University of Hospital Ribat, and he's going to talk to us today about the safe and optimal approach to breast disease. Mowia, the floor is yours. You can start.
Thank you, Professor Omar Al Farouk, my teacher. I hope to give you a beneficial talk today about safe and optimum approach to breast disease. In recent era, breast conditions management became more complicated. It is not as simple as previous, just to do mastectomy and exit clearance, but the management is become more complicated with many options, and this is because of many factors. Few of these factors I am going to mention. First, the most important is the greatest advances in breast imaging technology. The mammogram, ultrasound, and the MRI and other technologies give many new manifestation of the breast diseases, and so need different approaches. Also, the expanding pathological and immunohistochemistry and genetic classification of breast diseases also give many new options which need new modalities of management. And due to increase awareness and increase capability of early detection technologies, this lead to more conservative service options and complicate the things more. Advances in adjuvant and neoadjuvant agent also give new and more options. And now we are living in the era of evidence-based medicine and guidelines, which we have to follow, and we have to update our knowledge and experience. And the basic thing nowadays is a patient preference and rights. Nowadays, patients are well educated, aware about many things, and they can go to the internet and know more about their disease, and they know more options, and they ask you and discuss with you the different options, the benefit and the back draws of this option. And so it is not easy job to convince a patient of breast condition about a single plan of management. So nowadays they know more about the breast diseases, and they have the right to choose, and they have the right to know about each option. So you must be able to clarify, to discuss with the patient and these different options. Because of these factors and other factors, breast management condition is become nowadays more complicated. And as you know, that breast disease management in the past was belonged to the general surgery. Then it divided with breast and endocrine surgery. And nowadays, breast disease is alone, is a subspecialty alone, standalone, because it has wide discipline nowadays. Today, I'm going to give you basic things about the breast condition management. And this list of few of breast disease management option. Example, reassessment, screening protocol, analgesia, antibiotic, steroid, and and so a lot of options you can see here. And sometimes you will be uh, unable to choose one, and you will be wondering which the plan is suitable for this certain patient. So we are going with you, and especially the junior, my junior colleague, registrar and junior consultant, step by step uh, to handle this issue. I want to ask you or to give you an example. This is a real female came to me. Her age is 29 years old, had only one child, 2 years old, the child. She's not lactating. She is complaining of left breast lump during the 20 days prior to presentation, and also pain on touch, no discharge, and she had no significance in the past history or family history or no hormonal treatment history. On examination, I found there is a left upper outer quadrant, firm, mobile, smooth, well-defined, 3 times 2 centimeter mass. I want to answer this question. What is your clinical diagnosis? From the history and examination, what is your clinical diagnosis? I want to answer this question. Young female, one child, not lactating, has a left breast lump, and no significant family history and past history. Yeah, is there anyone to answer this question? Clinical diagnosis of this 3 times 2 centimeter firm, mobile, smooth, well-defined mass?
Okay, this could be a fibroadenoma.
Yeah, thanks, Dua. Yes. Yeah. Is there anyone has another opinion? So,
Hello, Mr. Mowia.
yes, welcome.
According to her age, fibroadenoma goes more with her. Yeah, I mean with her age. Yeah, yes, I will say fibroadenoma.
Fibroadenoma?
Yes.
Okay, okay. Yes. If it is fibroadenoma, what is your plan of management? What is the plan of management of this condition? Yeah, anyone? What are you going to do for her?
Of course, I will do for her ultrasound first.
Okay. Yes, good. But in the common practice here in Sudan, yeah, what are they going to do? Most of us.
Most of people used to reassure the patient only, or they can turn to surgical excision.
Yes, they are going to surgical excision. They said we will do excisional biopsy. Yes? Okay. But if you go in a systemic way, because if the patient is more than 35 years old, you will start with mammogram and complementary ultrasound. If she is less than 35 years old, you are going to start with ultrasound. If you need more imaging, you can do MRI or mammography in some cases, but MRI is best in the young because of the dense breast. The cut point is 35 years old, as you know, because of the density of the breast. Above 35 is density is low, below 35 density is high, and mammogram will not be useful in this age group below 35 years old. Also, in young female, we do not want to irradiate the young female breast, which is sensitive to the radiation of the mammogram, which is a type of radiation called soft radiation. So this patient is 29 years old, and we did for her ultrasound. We found the margin is irregular, and the irregular margin in ultrasound, if it is more than 25% of the circumference of this mass, we assume it as irregular margin as a criteria of the American College of Radiology, and it is suspicious for malignancy. After that, we did for her mammogram because in the ultrasound it is suspicious. So we did for her then mammogram because there is a benefit of mammogram to give you the whole breast view in one image. Ultrasound, the problem of ultrasound is operator dependent, and you may miss some lesion in between the probe movement. If you move it from one area to another area, you may miss some area, and the microcalcification, the small microcalcification also will not appear in the ultrasound. It appears only in the mammogram, but the coarse calcification can appear in the ultrasound. So there is a benefit of the mammogram over the ultrasound. Also in the mammogram, it is irregular and it is suspicious. Then we did for her core biopsy. The result was grade 3 invasive ductal carcinoma. So you see, we start the example, and it's a real example, a real patient that it seems clinically as a fibroadenoma. And the common practice here is you may go to excise this lump, and then you will discover if you send her for histopathology, you will find it as cancer. Some people, they do not send it to the histopathology, and the patient will come after long time later with metastatic disease or locally advanced disease. So this is a real example, and this is a common example facing us. And from this, I want to emphasize that the importance of imaging, And so, because imaging is important, the breast surgeon or the general surgeon treating breast condition must have a basic knowledge about breast imaging. So before you put your knife on the patient, you have to do image for the breast condition. So step of management start to assessment of breast disease. We start with assessment. After you assess the condition, then you are going to put the plan of management. The plan of management is better, must be discussed in MDT, multidisciplinary team. It is not only one-man show. It's not only the surgeon. the surgeon, the radiologist, the pathologist, the oncologist, and plastic surgeon, and other disciplines may encounter in these conditions. Then, after you formulate the plan, then you are going to implement this plan, whether surgical or oncological or others. And you have to evaluate the outcome of this plan of the patient, and then we accumulate our knowledge and experience in order to formulate a new guidelines to develop our uh, management plan in the future. So we will start with assessment of breast condition. Assessment of breast condition, good assessment will lead to formulate perfect plan. If you have, so you have to go slowly in the assessment step, not to jump over the steps. First, assessment start with history, examination, imaging, which is very important. The key role of assessment is through the imaging. A lot of conditions will not appear in the history, will not appear in examination, but you will find it in imaging, especially the early conditions will only appear in imaging. Pathology is final, it is the final say for the pathology. So these the steps of assessment: history, examination, and imaging. And I think there is no great problem in the history. Most of our colleague junior registrars, they can take history and they can do examination. In any case, the most important is localization of the lesion localization, because sometimes the patient speak about one lesion, complain of one lesion, and when you go to examine, you find another lesion, and you send for the imaging, they speak about third lesion, and if you send to pathology, they will take from another lesion. So we want to localize the lesion which we are speaking about exactly. The localization previously, they depend on the quadrant, upper outer quadrant, inner lower quadrant. The quadrant is a big area, and it will not localize the tumor exactly, because the patient may have two tumor in one quadrant. One is malignant and another is benign. So if you couldn't determine or localize the tumor exactly, we'll miss the case. Proper localization, as the recommendation of the American College of Radiology in the BIRAD system, is clock position and distance from the nipple. You said this tumor is in 9 o'clock. Not only that, the distance from the nipple is, for example, 6 centimeters, because you may have 2 or 3 tumor at the same clock position with different distance from the nipple. So each tumor must be localized clock position and the distance from the nipple, and the depth from the skin, especially with image ultrasound or something else, is beneficial for us as a surgeon. And for example, if a small lump is just subcutaneous, it can be a benign lump, it can be taken with local anesthesia. But if it is the same small lump in a deep breast, it will be difficult, and you may need to change to general anesthesia. So it will aid you in the formulation of the plan either it is local anesthesia or general anesthesia. So the depth from the skin, and also it is beneficial when it is a malignant cancer. You can, if it is deep away from the skin by more than 2 centimeters, nowadays it is not necessary to take the skin with it. If it is near to the skin, you have to take the skin with the malignant mass. So the depth from the skin is important information. It will aid you. This diagram show two lumps or masses at 3 o'clock. This is benign at 3 o'clock, and this is malignant at 3 o'clock. One away from the nipple by more than 6 centimeters, and this about 4 centimeters. So clock position alone is not enough. You need the clock position and the distance from the nipple to determine the exact localization of the mass. The breast, the protuberant part of the breast lie over the second rib to the sixth rib, and medially from the lateral border of the sternum to the mid-axillary line. But some breast tissue can extend up to the clavicle, and down to the eighth strip, medially to the midline, laterally to the posterior axillary line. And so, on examination, when you examine the breast, don't forget these areas. You have to examine from the clavicle to from midline, and here to the eighth strip, and here to the posterior axillary line. All this area, you have to examine it during examination of the breast. Many patients, they will come to you with a very far away tumor from the protuberant part of the breast. For example, in upper inner quadrant here, away from the nipple, just below the clavicle. And if you don't palpate this area, yeah, you will miss the case. So breast examination includes all this area. And in the future, next sessions, we will tell you about the mastectomy. All this area must be included in the mastectomy boundaries, because some breast tissue is extend to these areas. So this is important when you examining the patient. The major role is for imaging. So breast surgeon, and as I said, the general surgeon treating breast condition must have a basic knowledge of imaging. And usage of imaging start from screening, diagnosis, biopsy guidance, like ultrasound guided biopsy, stereotactic guided biopsy, or MRI guided biopsy, staging, searching for meds, and preoperative planning. Yes, very important in preoperative planning. Sometimes clinically you find the mass is not attached to the skin or attached to the deep muscle, but after you do image, the image show you the exact. Sometimes you find it attached to the skin, sometimes attached to the muscle, and so the staging will be changed and the plan of management will be changed. So preoperative planning is important to have a look to the image, and also the tumor localization will determine which type of for example, breast conservative or oncoplastic technique you can use. For example, the distance of the tumor from the nipple, if it is more than 2 centimeters, you can do breast conservative surgery. If it is less than 2 centimeters, it will be not perfect. And this mainly will appear more in ultrasound or MRI. pre and interoperative localization like wire localization or clipping or others like this. Safe specimen safe margin. Sometimes when you do breast conserving surgery, you send the specimen for mammogram, and you see exact safe margin you took with you in this operation. So in high risk patient, we do screening with MRI or mammogram. We follow up the patient after any treatment, also with imaging. So imaging play a major role in breast disease management. So I will go in some basic information about the imaging. I am not a radiologist, but as a breast surgeon, I have to know this basic knowledge about imaging of the breast in order to formulate a good plan. I have to know this information. The most important modality is a mammogram. Mammogram using a low dose of X-ray. It is a soft radiation. A soft radiation, it is more dangerous than the hard radiation, but the dose is a little bit low. The dose of radiation is equal to 2 or 3 months of environmental exposure. The dose is not high, but the type of radiation is a soft radiation, and this is not suitable for young female, except in extreme conditions. In pregnancy, you can do mammogram only if you badly need this mammogram. In malignancy only, and you can put a shield over the over the abdomen of the pregnant mother. It has 3 types: analog, which is old-fashioned, semi-digital, and full-field digital, which is stereotactic biopsy. The full-field digital is now recommended. Full-field digital with stereotactic device is recommended. In our situation here, most of the mammogram are semi-digital, and we hope in the future to have all mammogram are full field digital with high definition with stereotactic device. This is the mammogram. This is a stereotactic device. Okay. Better to look to the mammogram in a soft copy in a medical monitor with high resolution capability, but sometimes they give you the mammogram in the hard copy. As I said, breast imaging is a cornerstone in planning of formulation of the plan of the breast disease condition. So, me as a breast surgeon, I have to know whether this mammogram is done perfect. Technically, is it done perfect or not? Because if this mammogram is not including all the breast, is not fulfill the criteria of a perfect mammogram, so I may miss the case. I may miss a tumor. I may miss a microcalcification. I may formulate a plan in a wrong information about this mammogram. So from first glance, I have to check whether this mammogram is done technically accepted or not before to go to the findings of the mammogram. First, to detect whether this mammogram is accepted technically or not. in first, you have to look if is the nipple in profile. That means it is in the lateral side here and projected like this. Nipple in profile, clear. This is one of the more important criteria. And no skin fold. In the breast itself, I have not to see skin folding. If the technician does not apply the device well, there will be skin folding. And the problem of skin folding is that maybe there is microcalcification or a small tumor hidden in this skin folding, and I will miss the case, and the patient will come after time with advanced condition, and will be very sad. I have to see pectoralis major in the MLO. Sorry, in any mammogram, you have basically at least 2 view for each breast. The right breast here, we have the craniocaudal for the right breast, and we have craniocaudal for the left breast. And also here we have mediolateral oblique for the right breast, and here mediolateral oblique for the left breast. This is the basic view for the mammogram. When you said mammogram, that means the breast is viewed at least from 2 views, craniocaudal and mediolateral oblique. There are many others, up to 20 views, special views, used in special cases, but the basic is two views, craniocaudal and mediolateral oblique. In mediolateral oblique, I have to see pectoralis major lying like this, obliquely. But in craniocaudal, although it appears here in this breast, it is not necessary in any case to see the pectoralis major in the craniocaudal. But in MLO, you must see the pectoralis major. Nipple to pectoralis major distance must be with a difference in 1.5 centimeter plus or minus. I will show you the next slide. Inframammary angle must appear here. As you see my cursor here, down. Inframammary angle. I have to see this angle, because if I don't see this angle, I cannot guarantee that the inner part of the breast is visualized or in the image. So this angle is very important. Angle, and I have a technician is very competent to do this, who is called Sarah. So in Sudan here, I called it as Sarah angle. Sarah angle. She is very competent technician. Here is the measurement between the nipple and pectoralis major. You compare this with this. You measure in each breast. It must be with a difference of plus or minus 1.5 centimeter. If there is greater difference, that means in one view, the breast is not visualized completely. And there may be a hidden microcalcification or tumor or something else. So I have to look for this criteria in order first to make sure that my patient is probably imaged before to know the diagnosis, before to put the plan of management. For example, if the breast is huge, it can be divided. In this view, the mediolateral oblique cannot be all visualized in a single view. So you can divide the breast in many number of pictures to have the whole breast being imaged, especially in the huge breast. If you look to this, can someone tell me is this mammogram is accepted or not technically? What is the criteria is good in this, and what is the criteria are not fulfilled in this mammogram? Anyone? Anyone to answer?
Yes. Yes, doctor, can I answer? Hello?
Yes, welcome.
Thank you. From what I can see in the picture, the first thing is to look if all the nipple profile is visible. I think I can see all the nipples. The second thing to look for is that is the pectoralis major muscle visible, and I do not see the muscle in the lower pictures, the medial lateral oblique view. And I also do not see, I don't know how to see for skin fold, but I cannot see the inferior mammary angle in the medial lateral oblique view also. So it's not a complete imaging of the breast.
Yes, thank you, thank you. It's exactly what you tell us is exact condition, and unfortunately, this mammogram has been viewed by a radiologist, and he gave us a report. So the mammogram is not perfect. It's not perfect, and if you put a plan depending on a mammogram like this, you will miss the case. You will miss the case. So you are a breast surgeon. You are not a radiologist, but you have to know what is perfect in order to save your patient. So this mammogram will not be accepted and better to be repeated again. This tomosynthesis, it is like a 3D dimension formulated from the digital mammogram. Here is a digital mammogram with a special software. You can change the 2D vision to 3D vision in order to visualize what is not clear in this digital mammogram or ordinary digital mammogram. Here is not clear, but when you do it with a software tomosynthesis, it is appear like a speculate mass, and at the end it will give you a result of cancer. So this is special software attached to the mammogram. And ultrasound, at least you will need a high frequency ultrasound, at least 10 megahertz and more, 12 megahertz, 14 megahertz, and nowadays even in some centers there is 16 megahertz. The high frequency will give you more details about the tumor and characterize the tumor well. It is very important, the ultrasound in breast imaging. Most of the mammogram will need complementary ultrasound because, for example, a hyperdense mass, it can appear in the mammogram. If you do for it ultrasound, you will find it maybe solid or cystic mass. So it can differentiate more about the characteristic of the lesions. We have also whole breast ultrasound scan, automated, new modalities to overcome the problem of the operator dependent that who can miss some lesions in between the probe. This will give you a single image for the whole breast in one shot. Elastography also is a new modalities attached to the ultrasound, new software to the ultrasound, characterize the lesion more and give you the suspicious of either malignancy or benign. MRI also used in breast with it is high sensitive, but unfortunately low specific. The specificity is low, and so it will, if you use more MRI, you will have more unnecessary biopsy because it is high sensitive but low specific. So MRI must be used in a certain condition, not in any patient. For example, indication for MRI in multifocal disease, mainly like invasive lobular cancer, in recurrent disease, if there is discordant between image and biopsy, you can also go to MRI. In neoadjuvant chemotherapy, after neoadjuvant chemotherapy, if the tumor disappear clinically or in the mammogram or ultrasound, you can search for it using MRI. In occult primary disease, for example, if you have just axillary lymph node enlarged without any breast tumor in mammogram or in ultrasound, you can go to do MRI to search about the occult primary tumor. In patient have implant, silicone or saline filled implant, the best modality is MRI. In high risk patient like BRCA1, BRCA2 gene abnormality, the modalities of screening is MRI. Is the MRI. You can see here is a tumor, and the diagnosis mainly depend on the curve of the uptake of and stage and washout stage of the bite. Okay. After you check the mammogram and you accept the mammogram technically, there is next step is important to determine the density of this breast in the mammogram, because if the breast is very dense, appear in the mammogram, so the accuracy of the mammogram is low because there may be microcalcification or small tumor hidden in this dense tissue. So in order to assess the accuracy of this image of the mammogram, first, before going to search about the finding, you have to determine the density of the breast. American College of Radiology, they formulate density grading in A, B, C, D. A, the fatty breast. B is scattered glandular tissue. C is heterogeneous glandular tissue. D is extreme dense glandular tissue. Fatty breast is common in the post-menopausal women, and extreme dense glandular tissue is common in young female. In this group, the dense breast, it is better to go for another modality, ultrasound or MRI, to make sure there is no any tumor hidden in this dense tissue. So here in group D, the accuracy of the mammogram is very low. It's very low. Don't sit on that. The importance also of the density grading for the oncoplastic surgery, which means resection of the tumor with a safe margin and immediate reshaping of the breast using a plastic technique. The importance of that, one of these oncoplastic technique is glandular flap mobilization. You mobilize the glandular tissue to fill the gap which is formed by excision of the tumor. When you mobilize the glandular tissue, you are going to do undermine below the skin and also undermine between the glandular tissue and the muscle. So the blood supply of this glandular tissue will be devoid from two surfaces. In fatty breast, the blood supply is very poor. If you are going to do oncoplastic surgery in a fatty breast, you will end by fat necrosis. And this is better be assessed by the mammogram. Mammogram will assess you. If it is a fatty breast, better to avoid oncoplastic technique. Better to avoid oncoplastic technique. And more you have glandular tissue, you can do a safe oncoplastic technique without any jeopardize to the blood supply of this flap. So first, you determine whether you accept the mammogram or not. Then you determine the density grading, as I told you, for two reasons. Okay, and here is some examples for the mammograms. This is a normal dense nodular breast, as you see here. You see a mammogram is the X-ray. So the black is air, and the white, complete white, is bone or calcification. And everything is grading from white to black in a gray scale. But the more whitish here is the glandular tissue, and always we compare the MLO to the MLO, right to the left, and CC to the CC of other side, and the glandular tissue must be like what mirror image. Here you can see this glandular tissue almost like mirror image of the other side. If you want to comment, this is involuted breast, fatty breast. If you can compare, this is glandular breast, young female, and this is involuted postmenopausal. You see, there is no glandular tissue here. Here is just intermammary lymph node. This is intermammary lymph node will be make sure by, when using ultrasound. This is axillary lymph nodes. Fatty breast. Yes, intermammary lymph node is more common in the upper outer quadrant. This is the lymph node with the fatty hilum in the center. Here, example for fibrocystic disease. When you start to comment on the mammogram, you start from the skin here. The thickness of the skin is normally about 1 millimeter, except around the areola and in the inframammary area, the thickness of the skin will be more up to 2 millimeter. More than this indicate edema, like beady orange edema or inflammatory edema or something. So first you comment on the skin, and then you comment on the nipple, whether it is projected or inverted inside. And then you comment on the glandular tissue, whether it is symmetrical or not. If there any asymmetrical density in one side, you can describe this asymmetry, the location of this symmetry. Yes, about the location in the MLO, you draw a line from the nipple to the pectoralis major. Above this line is the upper part of the breast. Below this line is the lower part of the breast. In the CC, you draw a line from the nipple to the pectoralis major. This is the lateral side of the breast, and this is the medial side of the breast. This is very important to determine the location of the tumor by the quadrant in the mammogram. But when using ultrasound, you determine the area by the clock position and distance from the nipple. So this, and then you can describe, we have a lot of hyperdense round shapes, multiple in bilateral in both breasts, and this when you do ultrasound it appear a cyst, simple cyst, simple cyst. The characteristic of the simple cyst, which is very common, is the central anechoic area. In ultrasound, we grade the echogenicity in relation to the subcutaneous fat. In subcutaneous fat here, we said isoechoic if it is similar to this subcutaneous fat, and we said it is hyperechoic if it is more than this fat, and we said hypoechoic if it is low than this, and we said anechoic if it is black like the film by the side of the picture. So we have 4 grades: anechoic, hypoechoic, isoechoic, and hyperechoic. The cyst, characteristic of the cyst is anechoic center and lateral shadow. Here you can see this lateral shadow and posterior enhancement. This characteristic of simple cyst is very common. Yes, you can see here lateral shadow and posterior enhancement and central anechoic area. Because we have another type of this cyst, which is complicated cyst. When it gets infected, complicated cyst, you can see turbid content in the center, and also the wall of the simple cyst is very thin, sometimes imperceptible wall. You cannot see the wall. In infected cyst, the center will be turbid and the wall will be a little more thick. There is another type of cyst is called the complex cyst. Complex cyst, the wall of the complex cyst is very thick, and even sometimes you find internal growth inside the cyst. The complex cyst is mainly malignancy. Okay, so we have 3 types of cyst: simple, complicated, and complex. Cancer appear in mammogram like speculate mass, ill-defined mass, well-defined mass, intracystic papillary carcinoma, and inflammatory carcinoma. These major 5 appearance of the malignancy in mammogram, either mass or calcification. The mass has 5 types or shapes in the mammogram. The most famous is a speculate mass. If anyone has any question, I'm going fast or giving a lot of information. Okay. This is speculate mass. You can see star shape, and almost there is extension through the duct. You can see here the extension in the craniocaudal way. Okay, speculate mass with, you can see here the pectoralis major muscle is pulled towards this speculate mass, and also the skin over this area is pulled with what is called desmoplastic reaction or architecture distortion here, pulling this skin, and clinically you may not find this mass attached to the skin because it is a little bit far away, and also because of muscle fibers has a little mobility. Clinically, you can you can feel that this mass is freely mobile. And you formulate, you stage the patient as, for example, T2, N0. But if you now here in this mammogram, we see it's attached to the muscle and attached clearly attached to the muscle, just pulling the skin. We can give it as T4A because the skin is just with fibers. It's not direct invasion to the skin. These are just fibers, but to the muscle it is very near attaching to the muscle, so it will be T4A. So the plan of management will be changed totally. In clinical setting, you can say this is T2 and you are going to surgery, but here you find it attached to the muscle, which is T4A. That means it is stage 3, and this you have to start with new adjuvant. So imaging is very important in formulating a proper plan. This is speculate mass from near, like star shape or what. Here is another speculate mass pulling the nipple retraction with skin thickening. Yes, there is skin thickening here is clearly. Yes, another one speculate mass. Speculate mass, and you can see here like extension to the lymph nodes. Also, yeah, sometimes speculate mass with micro calcification. And this is important in the, if you want to do wide local excision just to the mass, leaving behind the micro calcification, it will be hazardous. So it is here clear. This is the speculate mass with all around microcalcification. So the plan of management, you have to sit beside this mammogram and to see exactly, it is the problem is not only the palpable mass you feel and you will do wide local and you run away. No, there is a microcalcification. You have, can you take it all in a wide local or oncoplastic, or are you going to do mastectomy for this patient? All this question must be answered, and you are sitting beside the image of the mammogram. You see this ultrasound. We said that microcalcification not commonly seen in the ultrasound, but sometimes you can see here microcalcification appear also in the ultrasound image. This speculate mass with old calcification, old maybe fibroadenoma calcified, which is called burned out fibroadenoma or popcorn fibroadenoma. And you see the calcification is completely white, but the mass is a little bit less density than the calcification. And this to differentiate between the mass and the calcification. This is very important to differentiate between a mass and a calcification. Calcification is completely white. The mass is a little bit gray. You see, it is clear from here. This calcified fibroadenoma, burned out fibroadenoma, and this is the mass, and also there is microcalcification besides the mass, speculate mass. Ill-defined mass also appear in mammogram here. Yes, ill-defined. You see the breast is fatty breast. There is no any glandular tissue. The density grading, which Which is density grading here? A, B, C, D.
A.
Yeah, yes, thank you. Irregular mass. Yes, irregular mass you see in the ultrasound. The cut point is 25% from the circumference. If more than 25% of the circumference is irregular, it will be classified as irregular mass. And multicentric and multifocal masses. Multicentric means in different quadrant. Multifocal in the same quadrant. And recent definition is if multicentric is the distance between the two masses is more than 5 centimeters. Yes, microcalcification. Multicentric. We said multicentric in you see the extension to the lymph node to the axilla. Yeah, this a tumor and this another tumor with ductal extension. The distance between the two masses, if it is more than 5 centimeters, we will assume this as multicentric. Multicentric, if it is more than 5 centimeters. Sometimes the mass will be well-defined. Well-defined mass. Well-defined mass. Clinically, you will say this is benign mass. But when you do ultrasound, you find it. And when you take biopsy, it comes as malignancy. You see this example, you see this well-defined smooth margin, smooth margin. If you palpate it and if you see it, you will say that this is a benign condition. A benign condition, but you see, this very well-defined, very regular margin, smooth surface, very nice tumor. Yes, unfortunately, it is intercystic papillary carcinoma, and you see this is example of a complex cyst. Complex cyst. You see, the wall of the cyst is very thick because the center is anechoic. The center is anechoic, and it is septated. The cyst is septated with a thick wall and a growth in the wall. Here, there is a growth in the wall. This definitely is malignancy. It's not a simple cyst. Simple cyst is benign. Complicated cyst is infected cyst. Complex cyst is a malignant cyst. And you need to take a trocar or core biopsy from this area, not from the fluid of the cyst. You have to target this area and you cannot do it blindly. You have to use the ultrasound guidance biopsy. Yes. Inflammatory breast carcinoma, it is a clinical diagnosis, as you know. But in mammographic findings, sometimes difficult to find a definite mass in mammography or ultrasound, and this may put the biopsy technique in trouble. Sometimes you cannot find any mass to take a biopsy. You can do bunch biopsy from the skin to find the infiltration of the skin lymphatic by the malignant cells. So sometimes it is confusing state. Clinically look like malignant. Some people from the start, they see it like mastitis, but do not forget, it is like mastitis, redness, hotness, pain, and tenderness. In this case, there is hyperdense mass. You can take biopsy from here. But in many cases, in inflammatory breast carcinoma, the biopsy is very difficult. Microcalcification appear here as extensive microcalcification. It is not always like this. It is have many types. For basically divided in the BIRAT 5 as four types: linear branching type, and segmental type, and amorphous type, and punctate type. With each one has a different index of suspicious of malignancy. The most suspicious one is the linear branching type. From nearby, the microcalcification, this is extensive microcalcification, and in this case, sometimes you cannot feel any mass, so clinical examination will not detect this patient. This patient, if you do clinical examination, you will say she is normal and send her back home, and she will come after a few months with metastatic disease. So clinical examination alone does not rule out the patient is free of cancer. When you take biopsy, if you want to make sure that you have taken the biopsy from the microcalcification, you put the specimen in the mammogram, and you do image for this, and you will find the microcalcification in your biopsy. So send it for histopathology. Microcalcification means ductal carcinoma in situ, early stage of breast cancer. Yes, this is taken with stereotactic device, and where localization. This, I think this is the one done by Mr. Omar Al Farouk. He is my teacher. I was his assistant in this operation. Yes. And after you take it with the wire, you make mammogram, and you make sure that the mass here is in center of the specimen, and you check the safe margin here. You can measure this safe margin from here to here, and also from here to here, and also from here to here. You measure the safe margin and decide whether the margin is safe or not. If you want to take in one side more, or you can do cavity shaving in all directions. This patient had been tumor and put a clip before using neoadjuvant. After given neoadjuvant, the tumor disappeared, but the clip is there, and the clip is localized with the wire, and then a specimen is taken out, and this is specimen mammography. So some people say that yeah, mammography is not necessary, has no benefit, it gives cost, more burden on the patient and health system. But here I enumerate causes for routine preoperative mammogram for any patient before doing surgery. You have to have mammogram because you want to make sure the contralateral side, the other breast, is free of cancer. This is very important. It is not only the breast that with ulcerating mass appear clinically as a malignancy. Is not all the story. There may be another malignancy in the other breast. So imaging is very important first to make sure the other breast is free of the tumor. Sometimes it may be bilateral, and the other side may be not palpable clinically. So you have to decide. And it is a medical legal document. mammogram ultrasound is medical document for any claim. Also, you have to determine whether the tumor is multicentric or multifocal in order to formulate a plan. As you know, multicentric tumor is far away of the boundaries of breast conserving surgery, the traditional breast conserving surgery. But in oncoplastic surgery, sometimes you can take the two tumors or more in a wide, safe margin and reshape the breast in one setting by oncoplastic technique. But the general rule is that multicentric tumor is not suitable for breast conserving surgery or therapy. So it will be determined by the imaging. So in another word, you cannot do breast conserving surgery without imaging. If you do just you take out the palpable lump, you may leave a microcalcification. You may leave another small tumor in far away in the breast, and this will not be a complete surgery, and the patient will come back with advanced disease and metastatic disease. So breast conserving surgery will not be done without imaging. Mammogram and basically mammogram and ultrasound. We have to have baseline before new adjuvant. Especially if I'm thinking after new adjuvant, I'm going to do breast conserving surgery. So I have to compare the mammogram before the new adjuvant and then after the new adjuvant, and to see how the tumor is reduced in size and the type of reduction of the tumor. Then I will decide to do whether breast conserving surgery or not. We have two types of the response of tumor to the chemotherapy. So when you give chemotherapy, the tumor in one type will shrink centrally and go to the center, and all the peripheral will be concentrated in a small area. This is called concentric type. Some other tumors will be fragmented into islands, small islands, and this is called honeycomb type response. And in this type, the breast conserving surgery is not suitable because the tumor is fragmented and you will not make sure that you took all the tumor. So these will not be seen only if clinically. You have to see it in image, mammogram and ultrasound. And as I told you, they may be a palpable tumor, but with microcalcification. If you take the palpable tumor and you leave the microcalcification, it is a problem. So mammogram is very important, pre-operative. If the decision is nipple and nipple sparing mastectomy or skin sparing mastectomy, you have to see whether the tumor extend to the nipple in order to have nipple sparing mastectomy, or the tumor extend to the skin or not. And this extension you can see in mammogram. Ultrasound is better. MRI is more beneficial in the decision of whether the tumor extend to the nipple or not. But ultrasound also is good. After neoadjuvant, if you want to do breast conserving surgery, you have to do it again. You have to do image again. So image is very important. Very important. Yeah, I can't imagine doing breast surgery without image. Where localization, I show you this one. Yes, you see here there is a hook here, hook attached to the area of the lesion. Here the hook is clear. We take out the mass and specimen mammography. You see the free margin. You can measure the free margin of your excision, and you can decide interoperatively whether you need to size more or not before you awake the patient. Ultrasound is very important in detecting the characteristic of the lymph node, whether it is benign or malignant. In this, there is a cortical thickness. Normally it is 2 millimeter. If it is more than 4 millimeter, it is significant. Between 2 and 4, it is borderline. And you see the center here is the fatty hilum. If it is absent, it is going with the malignancy. And if the vascularity of the lymph node is increased, also it indicates malignancy. So you have mainly 3 characters of the malignant lymph node: high vascularity, cortical thickness, either diffuse or focal cortical thickness, and absent of the fatty hilum. So mammogram is not perfect in the lymph node characterization. The ultrasound is a main. It is more beneficial even than MRI. Ultrasound in characterization of lymph node is the best. This infiltrated lymph node completely with loss of fatty hilum and cortical thickness, and it's become oval shape. Male breast also you can do mammogram for male. You see this is a male breast cancer in the left side. Yeah, you see nipple retraction. Yes. Intraductal papilloma, although it is very small, but it can be visualized in high frequency ultrasound with great accuracy. So I think we don't need to do ductogram and something like this. Nowadays, high frequency ultrasound can tell you whether there is intraductal papilloma or not. And even you can measure the vascular activity of this intraductal papilloma with this ultrasound. Phylloid also can be differentiated in ultrasound from fibroadenoma. You see this cleft. This is a characteristic of the phylloid. Okay, so no breast disease management without breast imaging. At least you will need digital mammogram and high frequency ultrasound. And I hope in my country, I hope that in any the head of the state, about 16 states in Sudan, we need in any head of the state, we need a center of breast imaging and diagnosis, and we need breast services, because nowadays all of patients came here to the capital, which is very bad, and we need this to be this service to be available in any state, and next step in any town. I hope that after the revolution, because the price of the mammogram is less than the price of the car of the who is the Al-Wali, the chief person of the state, as in the previous regime. They buy the car and they do not buy mammogram. Yeah, next step, triple assessment, composed of clinical assessment by history and examination, imaging, mainly ultrasound and mammogram, sometimes MRI, pathology, core biopsy or true cut biopsy. the confidence of this diagnosis is 99.9% if you do all these three steps. My question is that for any breast mass or lesion, would you have to go in these three steps, clinical and imaging and pathology? So in other words, will we need to do a triple assessment for any mass in the breast, for any lesion in the breast, any complaint in the breast? Someone to answer this question?
Yes, because the confident diagnosis for this mammogram is very high.
So are you going for any mass to do these three steps?
It depends on the virus.
Yeah, depend on the result of the image. Okay, why you don't do these three steps in any mass?
Hello, can I answer?
Yes.
If it's a very small mass in a female that's less than 25 years of age, and you are in your clinical exam, you are quite sure that this is likely a fibroadenoma, you don't have to do the full triple assessment. You can probably get away with doing an ultrasound and, for instance, a fine needle biopsy in this age group of patient and with that clinical exam.
Yes, thank you. In general, 80% of breast tumor are benign. The benign possibility, as you said, is increased with young age. But in general, 80% of breast tumors or swellings are benign. So if you are going to do these three steps, triple assessment for any mass, we will going to do 80% unnecessary biopsy. And with the advancement of the technology of imaging, nowadays the accuracy of the mammogram and the ultrasound, high frequency ultrasound, nowadays they reaching almost 95, 98% the accuracy. So we are not going to do the triple assessment for any mass in the breast. We will start with the clinical assessment and then go to the image, and then we stop at the image and we see the assumption of the clinical and the image together, and then we decide whether they is suspicious or not, and then we will go for the biopsy if we need. In order to be very objective, the American College of Radiology, they formulate the BIRAD system, breast imaging, reporting, and data system. And this is the 5th edition, which is in year 2013. And they want to the report of the image to be very specific and very objective to give you guide to the next step, whether to do biopsy or not. Because if we will do biopsy for any patient, we will do 80% biopsy unnecessary with burden on the health system and economical status of the country. And this BIRAD system, they put that the reporting is combined. If you, for example, if you did mammogram and ultrasound, the report will be combined together. Mammogram with ultrasound. They will not be one separate from each other. In either, because we at the end we want the end of the result, we want a clear decision. In Barat 0, the grade 0 means incomplete assessment. That means the radiologist is not sufficient to have a clear decision for this characterization of this lesion. So he may need further image, either a special view of the same image. For example, mammogram has a special view, magnification view, or other views, or you may need another modality. For example, you may need to have MRI or what else. So Barat 0 means incomplete assessment. Barat 1 means normal breast. And you say to the patient, you are normal, but you have to follow the usual screen protocol. For example, annual mammogram, if she is above 40 years to 69 years. Barat 2, it is benign. In benign conditions, you will discuss with the patient this benign condition. She can have usual screening or follow-up, or if she wish, you can do excision. For example, fibroadenoma or a benign condition, you can do excision. 3, Barat 3, probably benign. The probability of malignancy less than 2%. And the recommended plan in the Barat system is follow-up after 6 months. But sometimes the patient will be worried and she will say, I will not sit on the 2% possibility of malignancy. I want to know the exact diagnosis. Here you can do biopsy. You can do a core biopsy, throat cut biopsy. We have category Barat 4. It is suspicious for malignancy, ranging from 2% to 95%. Your action is biopsy, throat cut biopsy or core biopsy. We have Barat 5, highly suggestive of malignancy, possibility of malignancy more than 95%. You have to do core biopsy or throat cut biopsy. Barat 6, proved malignancy. You have to choose the appropriate treatment action. Barat 4 is divided because the range is too wide, from 2% to 95%. It is divided Barat 4A 2 to 10%, Barat 4B 10 to 50%, and Barat 4C from 50 to 95%. Each lesion has a different characteristic to be put in one of these category. Why? I'm going to ask why. You see here the action is biopsy in Barat 4, in Barat 5. And Barat 4 is divided into 3 categories. Why do we divide this? At the end, the action is the same. Why do we divide it this? Yeah, someone to answer? The action is the same. You have to take biopsy, but we divided it into. Why do we divide these categories? If it is Barat 5 and the result of the biopsy came benign, what is your comment?
Hello?
Yes.
Can I just, yes, so the reason for my thinking of the reason of why they divide it is that Barat 4 is only suspicious. So you need a biopsy to confirm your suspicion. The Barat 5 is suggestive and highly suggestive of malignancy, more than 95%, that you are going to get a malignancy. It's more for confirmation. Then the second question you asked, I can't remember. You asked the second question.
Yes. If the biopsy became benign in Barat 5,
Yes,
What is
then
your,
then there's a problem, because then you need to repeat your biopsy,
yes,
because you may have not got a adequate representation of the sample.
yes, yes. That is good. When the level of suspicious increase, that means you do not accept the benign biopsy. For example, in BIRAT 5, if it is become, the biopsy become benign, that means you have to repeat this biopsy. In BIRAT 4C also, the suspicious is from 50 to 95%. It is a great suspicious. You have to repeat the biopsy. But if it is BIRAT 4A, and the biopsy became benign, you can accept this because the suspicious is from 2 to 10%. In this middle group, it is, you can repeat according to the age of the patient and other factors. And if the other factors are not having high indication of malignancy, you can accept. So this will assist you in the acceptance of the result of the biopsy, whether you accept this result as benign or you repeat it again according to the level of suspiciousness of the tumor characteristic. Uh, this system makes the radiologist more responsible and assist us as a surgeon to take a clear decision. But in order to trust this BIRA system, you have to have a good machine, full field digital machine. You have to have a high frequency ultrasound. You have to have a good technician that do a perfect mammogram. You have to have expert radiologist to give you a very sharp cutting comment. So also we need here training in different parts of this technician. We need radiologists to be trained more and more. Okay, pathology is recommended is a core biopsy. If it, or you can do it with a true needle biopsy. Also, you can do it. Blind, if you can take it blindly, if it is the tumor is big, but the preferable is image guided biopsy, ultrasound guided biopsy, or stereotactic biopsy, or mammogram. اللي هو the stereotactic is using the mammogram. MRI guided also is used in some conditions. Blind, the benefit of guidance in palpable lumps, you will avoid the necrotic areas. The center of the tumor sometimes it become necrotic. If you take from the center blindly without image guidance, you will have necrotic tissue. And also you can avoid the fibrotic reaction around the tumor, desmoplastic reaction. And in the complexes that I show you before, like intercystic papillary carcinoma, it is difficult to take it blindly without ultrasound because you want to target the wall of the cyst. You are not going to target the center of the cyst, which is composed of fluid. Also, you avoid, by the guidance, you avoid the trauma to the chest and the vessels, especially in the axilla when you take axillary lymph node biopsy. And image is obvious, must be used in impalpable tumors. So impalpable tumor, you cannot take it with your hand blindly. You have to have guidance. So guidance image is the preferred. But in our situation here in Sudan, it is some difficulty to have the suitable place and person for guidance. So now I train my registrar about the proper technique of taking the throat cut, even in the setting of the clinic under local anesthesia. We can make a workshop on that. Excisional biopsy, I think it is a problem. I'm asking, is it excisional done to have biopsy? You take it to have a diagnosis, or you take the mass to treat the patient? For example, the first patient, the first example, when some people said that we are going to do excisional biopsy, do they do it to diagnose what is the condition, that means of biopsy, or do they do it to treat the condition of the patient, to get rid of the lump? I suggest that we have not to use excisional biopsy, because biopsy in the breast recommended is true cut biopsy or core biopsy. So if you want to do biopsy in the breast, you have to do it as a true cut core biopsy. Because if you take it to diagnose, problems will happen. And this few of these problems, most of this excisional biopsy will be done under local anesthesia. Local anesthesia will not give you the chance to take the lump good. Definitely will not have safe margin with the local anesthesia. Pardon, someone?
Continue, sir.
You will not have safe margin with local anesthesia. Proper safe margin will not be done under local anesthesia. The specimen will be fragmented. In many cases, fragmented, and so you cannot orient the fragmented specimen. And so if the margin became positive margin, you cannot know which margin is involved, and you want to re-excise this margin. Some people not send the mass for histopathology, and these make a lot of problems. If someone says that from the start, I will go to take the mass under general anesthesia with a safe margin. So if it became malignant, this patient, invasive cancer, this patient will need a second operation for the axillary dissection. And this means that anesthesia for the second time, and payment a patient will pay for on the second time, and the health system burden to double the work. So it is better from the start to diagnose through the core biopsy or through cut biopsy to decide whether it is malignancy or not. If it is malignancy, the operation will be one operation. If you do excisional biopsy, as they said, and the mass became malignant, although with a safe margin, but here you will lose the chance of having a sentinel lymph node biopsy if the lymph node is not enlarged clinically or under ultrasound. Because when you take the mass, the lymphatic drainage of this area will be cut and blockage with the inflammatory and hematoma of that area. And when you inject methylene blue or radioisotope, you cannot guarantee that this radioisotope or blue dye will go to the sentinel lymph node biopsy. So you will put this patient in a one chance, in one option for just axillary dissection. She will lose the chance of having sentinel lymph node biopsy and the chance of avoid the complication of lymph node dissection, that lymphedema and others. So the patients has the right to know from the start, because before going for surgery, the patient has the right to know whether she have malignancy or benign, and she has the right to decide she want to do the operation with you or with another one, or even she do not want to do the surgery, or even she want to go abroad. And nowadays the patients are very educated, and so when you go directly for excisional biopsy, you will put her in the track that if she was knowing that this malignancy from the start, she may choose another option. So this is another problem of excisional biopsy. So my recommendation is that do not do excisional biopsy. Go clinical assessment, imaging assessment. If after image the condition is benign and you want to treat the patient, you excise the lump. Excise the lump as a treatment. But as a general rule, any tissue that excised from a patient must be sent to the lab investigation for the histopathology. You excise and send it. But if I have any suspicious from the start, I have to take true cut or core biopsy. This, I think, a point of debate. Some patients, they have ulcerated mass, and clinically looks like malignant ulcerating mass. In this case, you can take incisional biopsy because the ulcer is already open. You can just, with local anesthesia at the side of the ulcer, and you take a small piece from this ulcer, you send it for histopathology. This has no problem, it cut it short. But excision of a lump, it must be after the clinical and image assessment, and without any suspicious. For example, by RAT 2 or even 3, you can excise. This is a core gun. Yes, this is a true cut needle. This is a fine needle. If anyone have any comment on the problem of the excisional biopsy, please don't do excisional biopsy. You do excision for the lump to treat the patient after you make sure there is no suspicious clinical and radiological, no suspicious. You can excise the lump and send it for histopathology. Is there anyone has any comment in this?
Mr. Assalamu alaikum.
Alaikum assalam.
Assalamu alaikum, Mr. Hawir.
Alaikum assalam.
Sometimes even core needle biopsy is not conclusive. Despite that, the patient the condition of the patient is highly suggestive of malignancy. So what can we do in this situation?
Yes, this it can happen, but I think it is a little bit rare condition. Sometimes I repeat core again under image, and sometimes you can do incisional, you can do, yes, excisional, but it is very rare condition. It is not the general rule.
The other thing that so that you didn't speak about fine needle respiration cytology.
Yes, the next slide will be about the comparison between fine needle and the trocar.
Okay, thank you, Mr. Mahali.
But I put this recommendation because here in Sudan we're facing a lot of problems. A lot of patients, they go for a doctor clinical examination. They found the lump. They take it
Yes.
directly without doing any image. After
So
taking it,
it's obsolete now. It is traditional practice only.
yes.
Mm.
So I have a junior registrar, and I want to stress on this to stop this practice.
Thank you, Mr. Maya.
Thank you. Thank you.
Sir, Assalamu alaikum.
This is a fine needle aspiration cytology. You see, it is done with 10 mil syringe with a needle gauge 21 gauge. This is comparison between the core and the fine needle. Uh, Obviously, the core or through cut biopsy get out of tissue, and here in the fine needle we have cells. So the diagnosis is more accurate in the tissue base more than the cell. Uh, it differentiates between the invasive and in situ, and this is very important. Fine needle cannot differentiate between invasive and in situ, and this is important whether to have any action in the axilla. In invasive cancer, you have either sentinel lymph node biopsy or axillary lymph node dissection. In tissue biopsy, we have less false negative, especially if it is done under image guidance. In the fine needle, we have more false negative, and unfortunately, sometimes we have false positive, which is very catastrophic, because a fine needle become as malignant, and you go and you do mastectomy, and the patient lost her breast, and the final histopathology came as benign. So you will be go under the table. Need less experience in the true cut biopsy for the pathologist, and fine needle need expert cytologist to reveal the cells and read the result. In the core biopsy, you can do receptors, estrogen receptors, progesterone receptor, HER2, Ki67, and these aid in the planning of management of the patient, either to choose surgery or neoadjuvant. Here in fine needle, you cannot do cannot do the receptor. Although some cytologists said that they can do cell block after centrifugation of the specimen, but I think it is very difficult and not applicable in any cases. If you have fine needle and you did not do the receptor, and you give the patient neoadjuvant, and then after the surgery you do the receptor, the chance of changing the receptors by the action of the neoadjuvant chemotherapy is about 10%. There will be a change in the result. So true cut is recommended. True cut for biopsy is recommended. Fine needle in the breast is not recommended nowadays, unless in the axillary lymph nodes, and especially if it is near to the axillary vein and you are afraid to hit the axillary vein. Bunch biopsy in Paget's disease, or sometimes we do it in Paget's disease. Incisional biopsy in ulcerating tumor, sometimes also easy to do it in ulcerating tumor.
معاوية
You-
السلام عليكم معاوية
yes,
معاك عمر الفاروق. Just for the sake of time, and I'm sure most of the registrar now they have very important question to ask you. Just for the sake of time, it is very interesting lecture and very rich in information. I suggest that we need more of these lectures, and I'm sure you are going to continue with giving the rest of the series for the breast diseases. But just for the sake of time, I will suggest that we stop here and give the chance for the registrars to ask question, if you don't mind.
Okay, okay.
And then we have another session. I think we'll have another session to continue more. Are you about to finish, or there is a lot, or there is something more?
And I didn't hear it. Or...
Are you about to finish ولا يعني لسه باقي لك كتير؟
Can you raise your voice a little bit? Sorry.
معاوية معلش صوتي ما واضح كده واضح؟
أيوة.
بقول لك do you have a lot more? Do you have more slides, or you are about to finish?
No, I already I finished.
Because
I finished.
if there is more, then I will suggest that we'll have another lecture, and definitely we need more lecture from you to tell us more about the rest of the story of the breast diseases. I think it is now time for the registrar to ask questions. You can go, and if you are about to finish, you can go and finish a few slides.
Yes, this is the last slide.
Okay.
Message to take home. We have to stop the false reassurance of the patient. The patient. Yes. Just I want to raise this point. What is the difference between early detection and early diagnosis? Early detection means awareness and screening protocols. Yes, but early diagnosis means that when the patient came to you, you have not to miss this patient. We have a lot of patients came to doctors and they missed the diagnosis, and so they will come later on by advanced disease. So the importance of image is to aid you in not to miss the cases. So this is the concept of early diagnosis. And the last slide is we have to stop false reassurance. False reassurance when the patient came to you, don't reassure her unless you do clinical assessment and image assessment. And because clinical examination alone cannot tell the patient is free of cancer. Clinical examination alone cannot tell the patient that is free of cancer. So breast imaging is mandatory for management planning. And sometimes there is a recommendation from some radiologists that after they do imaging, they said to you excisional biopsy. The recommendation is that is true cut biopsy, This is most important. I want you to take this as the last. Thank you for listening. Sorry for long lecture, but the topic is too huge.
Yes, Muhammad.
Thank you very much, Mowia, for this nice presentation. It was very, very informative and very useful. And I'm sure everybody from the audience benefited a lot from your information. It is very rich in information. And especially for the registrar, Mowia today explained the basic of imaging very nicely, very simply. And I'm sure everybody benefits from that. We hope that you're going to continue with the series of breast diseases, so our registrar can make use of your information. I have a comment that Mowia explained very nicely that we need now to do imaging. There is no shortcut in breast diseases. If you have a patient with a lump, you have to do a mammogram if the patient is in the age group for mammogram, and you have to complement that with ultrasound. Nowadays there is no mammogram alone if you have a lump or a diagnosis in a mammogram, you have to complement that with ultrasound. Ultrasound will tell you the exact size of the lump. It will tell you if it is malignant or not. It will tell you if there is nipple extension or not. And it will tell you if there is lymph node involved or not. And these information are very important for your decision making. And the other thing which Mowia explained very nicely is the BIRAT system that will help in making a plan for the patient if you need to do a biopsy or not. And he raised a very valid point, because nowadays, if a patient presents with a small fibroadenoma, you'll find that the registrar, they will send them immediately for fine needle aspiration cytology. And that is not now, it's not the standard practice. The standard practice, if it is benign, small, and the age group is young, you don't have to take a biopsy from this lesion. You have to follow them up. And Mao explained that very nicely. Now I will open the floor for questions to Mao. If you have a question, please unmute yourself and ask the question.
I think, Mr. Umar, we have Prof. Rashid with us, and also Prof. Ahmed Al-Amin al-Sheikh.
Okay, Prof. Rashid.
Thank you, Omar. Thank Mowia. This is a very educating session. Really, congratulate you on this. The first, I like your first slide about the anatomy of the breast from the second to the sixth rib. So I think this is important, because our oncologists here, sometimes they comment that the patient coming with a mastectomy is not really a mastectomy, they can feel even. So please be very careful about the anatomy, not only for the breast, but I think for any type of surgery you do, go and read your anatomy very well. The second comment, the tumor board, I think this is an important. I mean, all over the world, people usually sit together, and because of the difficulties here, sometimes it's not easy to find. But I really commend Umar or Mowia because of establishing a breast unit now, because I mean, breast surgery is becoming a specialty on its own outside. But now here, as you know, that we are starting with the general surgery with a bias towards one of the aspects for many reasons. I mean, probably teaching of the students, of the registrars, and even doing our private work and other things. Well, for the excision biopsy in young patients, you said that 80% of these are benign, and you depend on imaging. But my comment in the imaging, we're not talking about Khartoum, we're not talking about the special area, because ultrasound now, everybody has got a machine of ultrasound. You don't know who is he, because there is no criteria really, because I think ultrasound now, because it is an operator dependent. I mean, usually you want to know who is the ultrasound. And the other thing, I think for a 20 years old girl coming from a village probably, and with a certain sum of money, and the family is worried, usually they think this is a malignant. We don't have the insurance for all aspects, because I think at 20 years coming with a fibroadenoma, I will do an excision under local anesthesia. That will be one pay for the histopathology, because if you write ultrasound and mammography, they will calculate it, and at the end of the day, they cannot afford it, they will disappear. And I had actually practically cases like this. So I think you have to assess every patient on its own. I know, I mean, now people are getting more educated, female, knowing they come for their own screening. So whatever what you said is applicable for many, but you have to be very careful about surgeons or residence registrars working probably in far provinces, and they have these slumps. Sometimes they are pressed to do. Excisional biopsy, just for a young case, I agree, for any suspicion of malignancy is a true cut. Fine needle aspiration does not protect you from medical legal aspects. And I have been called actually in the medical council for somebody who did a mastectomy for a young girl at the age of, I think, 30, because the fine needle aspiration was malignant. But you cannot defend yourself, and you say that you are doing a mastectomy because the fine needle. So I think I agree with you that a true cut, and even a true cut, it has to be done really properly, because if you don't do it properly, you might miss it and you might get the force negative. My first comment is that actually we have to have our own data. I think I was actually traveling to one of the cities, and they have got an oncology department there. And one of the chaps wanted to do a thesis, and we found 200 cases of breast. But when we went through the files, unfortunately, no data. So I think we need to keep data. And we can have, I mean, I agree with the international classification, but as you know that in evidence-based medicine, the third component is local experience, which is probably dictates what you do. So might differ in these aspects. So we have our own modification, which is really suitable for our local conditions. And I agree with you in Khartoum, the development now with this, I mean, people getting more educated. But if you go outside, I think in the regions, probably the practice has to be modified according to the local situation and local understanding. Well, thank you again, Omar and Mowia. Very enriching and very educating session.
Thanks, Professor Rashid. Really, in current situation in Sudan, in the faraway people and lack of facilities like ultrasound, like, yes, and also financial problem. Sometimes put you in the special consideration.
بروف سليمان خليه موجود برضه في السيشن يا مستر عمر.
Prof. Suleiman, if you have any comments, and our registrars, if you have any question, please unmute yourself and ask.
محمد علي, you are welcome.
السلام عليكم مستر عمر, مستر معاوية. I have one question about the. We know true cut biopsy and core biopsy is superior to fine needle aspiration. ولكن في what about small lumps? 1 to 2 centimeters, small lumps that we cannot take it with true cut biopsy. We cannot do core biopsy on it. If أنا قاعد في حتة I don't have the facility to do stereotactic mammography. Your approach from your experience. Excisional biopsy with wide local excision, or you will go for fine needle aspiration cytology?
Fine needle is not accepted. It's not accepted. The result of fine needle is not accurate. I think if you have no any facilities, better excision with wide local, with safe margin, better than to do fine needle. But here in our settings, we have ultrasound guided, and also we have stereotactic, even just for microcalcification, not the lump. Just microcalcification, we can take it with stereotactic biopsy. But if you're far away, I think you have to tell the patient, to tell the patient that the best is image-guided biopsy. Sometimes you look to the patient that he is far away and the general condition, economical status, look, he is poor. But when you tell him that there is a best option, better option, he can travel, he can come to the best option. So best, the patient have the right to know the options, and then he choose. If he choose to stay with you in a far away, I think wide local excision with safe margin is best than FNA.
Thank you. The other question, Mr. Malish, you said إنه accuracy is 99.9% with triple assessment, لكن you don't need it. يعني to go for biopsy, if يعني you have a good Pirat system أو good operator to do mammography and بيطلع لك بالبيرات إنه والله this is probably كده. This is in benign conditions ولا في malignant conditions؟ لأنه one of the indications of neoadjuvant chemotherapy is أنا if I'm omitting the biopsy and the receptor status, one of the most important indications اللي هي poorly differentiated carcinomas بغض النظر عن السايز، بغض النظر عن الريسبتور ستاتس. This is for neoadjuvant. أنا ما فهمت إن هي for benign conditions يعني result from the Pirat system جات benign، بعد ذاك no need for biopsy just follow up، ولا if malignant أنا I have to do biopsy.
لا التريبل اسسمنت الاكيورسي 99%، تريبل اسسمنت فيه البايوبسي، ده التريبل اسسمنت. لكن انت ما بتحتاج you don't need to do triple assessment in all cases. In all cases, because 80% will become benign. So, in order to have unnecessary biopsy, we just do clinical examination, and then we do image, and from that we decide whether it is BIRAS 4 or 5. Then, for these two groups, you will do true cut biopsy.
يعني كلام
thank you,
معاوية
sir.
يا محمد انه اذا انت جاك البيشنت بلمب whatever it is you have to do the imaging. اذا كان benign اللي هي BIRAD 1 or 2 or 3 then you can follow up the patient.
Yeah.
If it is suspicious 4 or 5 then you have to go for biopsy.
Yes.
Okay.
Okay.
BIRAD بيتعمل لكل اللمب.
اوكي مستر برضو لاست كويشن، معلش طولنا عليكم عشان ندي فرصه للناس. الكليبنج before neoadjuvant chemotherapy with mammogram هل هو روتينلي for every patient؟ لانه بعدين بيقبل المشكله اذا انا if I'm not doing the clipping ولا الماركينج والبيشنت بقى completely responder to the chemotherapy without clipping. البلان اوف مانجمنت، وهل هي شغله ماشيه على انها هي تقبل كليبنج تو كليب بيفور نيو ادجوفنت كيموثيرابي ولا كيف؟
الكليبنج they are two groups you expect that you will have good response for the chemotherapy. The group of triple negative and the group of HER2 positive. These two groups will respond well to the chemotherapy. And this is one factor. And the other factor is the size of the tumor. If the tumor is small, you expect after the chemotherapy, it will disappear. If you have these two factors, the receptor factor and the size of the tumor, from the start you decide to clip the tumor. And during the chemotherapy course, the oncologist, after each session of chemotherapy, will assess the patient. If the tumor is going to decrease very dramatically, and the oncologist at this stage he can advise to have the clip. And the clip, I ask my patient from the start, would you like to have mastectomy or wide local? If the patient is already her decision from the start to have mastectomy, I think no, you don't need to put the clip. But if the patient have the idea of having wide local excision, you have to put the clip in order not to lose the area of the tumor.
Thank you, Mr.
Any more questions?
Good afternoon. I'm Hala Salah, Visceral Plastic Surgery. Thank you for this session. We really enjoyed it. It's really informative. And can you hear me?
Yes.
Okay. My concern is that you said the benign condition are 80%. I think we need to know more about them, especially the imaging, the diagnosis, when to stop and reassure this lady. I think we need a session that with generous informative information about these 80% condition of breast. My question is that, I have two questions. The first one, can we follow the patient concern although her investigation, clinical examination and imaging was reassuring? Can we respond to her concern regarding the surgery and to clip that mass to just reassure her? And my second question is that as a plastic surgeon, do you discuss the perioperative reconstruction option with each single lady? I think we have to increase awareness for those ladies that the reconstruction is here in Sudan and it will help them psychologically and they will have a better life after the reconstruction. Thank you.
Yes, yes, we give them the option of reconstruction. Yeah, few of them they agree of that, but the majority they choose mastectomy. They believe in mastectomy. They said that just take it out, just take it out. But the things I think is going on, yeah, and we offer them reconstruction. The second question, you said that you need a session on benign condition. Yes, I think I have three basic sessions. The one here I gave you is assessment. The second will be about planning, how to plan the management, especially about the malignant condition. Then we have third one about the tips of surgical tips like mastectomy, axillary clearance, and so on. And we with someone, or we can see about the topic about benign. Yes, we can arrange for this. But I didn't understand the first question you said.
I said if the patient concerned about her lump in the breast was not reassured by imaging and examination, we reassure her this is benign, we examine her, we have an image, and so all are benign. And despite that, she wants to have this lump taken out. Can we respond to her concern?
Yes, yes. For example, if a young lady and came to you, you assess clinically and you assess by ultrasound, the conclusion is fibroadenoma. In this setting, usually I give them about options. Option of follow-up, you do ultrasound after 6 months again. The second option, yes, excision. You can take it out because psychologically the female feels that there is a lump in her breast. Morning and night feels this. It will be troublesome. Sometimes the fibroadenoma huge, giant, distorting the breast, discomforts the patient. Sometimes the location of the fibroadenoma is near to the ducts, compressing the ducts and maybe affecting the future lactation of this female. So yes, you discuss with the patient, and you respond to the patient concern.
Mr. Muhtasim.
Thank you, Mr. Mowia, for this updated talk. Thank you, Mr. Omar Farouk, for his moderation, and Professor Rashid for his participation, great participation. My question that I need to know the effects of physiological changes of that happen to the breast in a pregnant lady and lactating lady. The effects on techniques of doing imaging and taking biopsy. How is it going to affect the results, and is there any difficulties with these physiological changes?
Yes. During pregnancy, the breast engorged, and also during lactation. For example, mammography will not be will not be beneficial, and also will be a little bit harmful because the breast is active in this time. So always we postpone the mammography. We depend on ultrasound. The biopsy, the most important thing is to tell the pathologist that this patient is pregnant or lactating, because the histopathology of at that time the breast glandular tissue would be more active, and this will affect the grading or even of the grading of the tumor or even the diagnosis. So the pathologist must know that this patient is pregnant or lactating.
Mowia, thank you very much for this excellent and very informative presentation. We benefited a lot, and I'm sure everybody benefited from your lecture, and we are waiting for more the rest of the series. I think it is becoming late. We thank Mowia again for this nice presentation, and we hope to see you again. Thank you everybody for your joining the Sudanese Club, and thank you, Mowia.
Thank you. Thank you.